Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching medical and surgical nursing. Today, we'll be talking about the management of patients with diabetes. Diabetes is a group of metabolic diseases characterized by hyperglycemia, resulting from defects in insulin secretion, insulin action, or both. Care of the patient with diabetes, formerly known as diabetes mellitus, but now more commonly referred to as diabetes, requires an understanding of the epidemiology, pathophysiology, diagnostic testing, medical and nursing care, and rehabilitation of patients with diabetes. Nurses care for patients with diabetes in all settings. Now let's discuss insulin. Insulin is a hormone secreted by beta cells, which are one of the 4 types of cells in the islets of Langerhans, in the pancreas. Insulin is an anabolic or storage hormone. A deficiency of insulin results in diabetes. Now let's discuss the actions of insulin. When a person eats a meal, insulin secretion increases and moves glucose from the blood into muscle, liver, and fat cells. In those cells, insulin has the following actions. First, it transports and metabolizes glucose for energy. And it stimulates storage of glucose in the liver and muscle in the form of glycogen. And it also signals the liver to stop the release of glucose. Next, it enhances storage of dietary fat in adipose tissue. It also accelerates transport of amino acids into the cells. And lastly, it inhibits the breakdown of stored glucose, protein, and fat. Now let's proceed to glucagon. Glucagon is secreted by the alpha cells of the islet of Langerhans. It is released when the blood glucose levels decrease, which stimulates the liver to release stored glucose. The insulin and the glucagon together maintain a constant level of glucose in the blood by stimulating the release of glucose from the liver. Now let's have the different classifications of diabetes. First, we have type 1 diabetes, then type 2 diabetes. We also have gestational diabetes and diabetes associated with other conditions or syndromes. Lastly, we have pre-diabetes. Now let's have type 1 diabetes. It is a metabolic disorder characterized by the absence of insulin production and secretion from autoimmune destructions of the beta cells of the islets of Langerhans in the pancreas. And it is formerly called insulin-dependent diabetes or juvenile diabetes. In this type of diabetes, the pancreas does not produce insulin, thus there is no production of insulin in the body. Now let's proceed to type 2 diabetes. It is a metabolic disorder characterized by the relative deficiency of insulin production, a decreased insulin action, increased insulin resistance. It is formerly called non-insulin dependent diabetes or adult onset diabetes. In type 2 diabetes, the stomach converts food into glucose, the glucose enters the bloodstream, and the pancreas creates sufficient insulin but the body is resistant. Glucose is unable to enter the body effectively. Thus, the glucose levels rise in the bloodstream, damaging the blood vessels. So in your type 2 diabetes, there is a sufficient insulin produced by the pancreas. However, the body is resistant to insulin. Next, we have gestational diabetes. Any degree of glucose intolerance with its onset during pregnancy. Hyperglycemia develops during pregnancy due to the secretions of placental hormones which causes insulin resistance. We also have diabetes associated with other conditions or syndromes. It is previously classified as secondary diabetes. It is accompanied by conditions known or suspected to cause the disease, such as pancreatic diseases, hormonal abnormalities, medications such as corticosteroids and estrogen-containing preparations. Lastly, we have prediabetes. It refers to a condition in which blood glucose concentration falls between normal levels and those considered diagnostic for diabetes. It occurs when your blood sugar is higher than normal, but it's not high enough for a diagnosis of type 2 diabetes. It is classified as impaired glucose tolerance and impaired fasting glucose. Now let's proceed to clinical manifestations of diabetes. We have here classic symptoms or the 3 P's. We have polyuria, which means increased urination. We have polydipsia, increased thirst, and polyphagia, increased appetite. The patient might experience fatigue and weakness as well, sudden visual changes, tingling or numbness in hands or feet, dry skin, skin lesions or wounds, which are slow to heal because of compromised circulation due to the viscosity of the blood caused by increased blood glucose level in the blood. Unexplained weight loss. For the assessment and diagnostic findings, we have patients with diabetes have abnormally high blood glucose level, and this is the basic criterion in diagnosing diabetes. We also have fasting plasma glucose. It is a blood glucose determination obtained in the laboratory after fasting for at least 8 hours. We also have random plasma glucose and 2-hour post-load glucose. So here is a blood sugar levels chart. So we have here normal, pre-diabetes, and diabetes state. We also have here values related to such status. For example, in normal, if the patient underwent fasting, so the normal value should be from 70 to 100 milligrams per deciliter. For the 2 hours post-meal, we have less than 140 milligrams per DL. For pre-diabetes fasting, we have 101 to 125 milligrams per DL, and for 2 hours post-meal, it should be within 140 to 200 milligrams per DL. For diabetes status, we have more than 126 milligrams per DL under fasting, and we have more than 200 milligrams per DL for 2 hours post-meal. We also have an equivalent of millimole per liter values here. So these are the blood sugar levels that you would consider if your patient is normal, has a pre-diabetes state, and diabetes state. Now let's proceed to criteria for the diagnosis of diabetes. The patient can be diagnosed through symptoms of diabetes plus casual plasma glucose concentration equal or greater than 200 milligrams per deciliter or 11.1 millimole per liter. Casual is defined as any time of the day without regard to time since last meal. The classic symptoms of diabetes include polyuria, polydipsia, and unexplained weight loss. We can also diagnose diabetes by way of fasting plasma glucose greater than or equal to 126 milligrams per DL or 7 millimole per liter. Fasting is defined as no caloric intake for at least 8 hours. Also, we can diagnose diabetes by 2-hour post-load glucose equal to or greater than 200 milligrams per deciliter or 11.1 millimole per liter during an oral glucose tolerance test. The test should be performed as described by the World Health Organization using a glucose load containing the equivalent of 75 grams anhydrous glucose dissolved in water. In the absence of unequivocal hyperglycemia with acute metabolic decompensation, these criteria should be confirmed by repeated testing on a different day. The third measure is not recommended for routine clinical use. Next, let's proceed to the medical management. So we have goals here of treatment to achieve normal blood glucose levels, that's your U, glycemia, without hypoglycemia while maintaining a high quality of life, and also to normalize insulin activity and blood glucose levels to reduce the development of vascular and neuropathic complications such as retinopathy, wherein small blood vessels that nourish the retina in the eye are damaged. We also have nephropathy, the kidney cells are damaged, and neuropathy, nerve cells are damaged. Now let's proceed to diabetes management. We have nutritional therapy that includes meal planning and related education. We also have exercise. Exercise recommendations and precautions should be taken into consideration when we talk about exercise for diabetes. We also have monitoring glucose levels and ketones that includes self-monitoring of blood glucose, continuous glucose monitoring system, and testing for glycated hemoglobin. And lastly, we have your pharmacologic therapy. Now let's discuss medical nutrition therapy. Nutritional therapy prescribed for the management of diabetes usually administered by a registered dietitian who designs and educates about the therapeutic plan. Nurses and all other members of the healthcare team must be knowledgeable about nutritional therapy and supportive of patients who need to implement nutritional and lifestyle changes. Now let's proceed to glycemic index. The term glycemic index is used to describe how much a given food increases the blood glucose level compared with an equivalent amount of glucose. So the carbohydrates are ranked from 0 to 100 according to how much they cause the blood sugar to rise after they are eaten. Now let's proceed to exercise. Exercise is extremely important in diabetes management because of its effects on lowering blood glucose and reducing cardiovascular risk factors. Exercise lowers blood glucose levels by increasing the uptake of glucose by body muscles and by improving insulin utilization. It also improves circulation and muscle tone. Resistance or strength training, such as weightlifting, can increase lean muscle mass, thereby increasing the resting metabolic rate. These effects are useful in diabetes in relation to losing weight, easing stress, and maintaining a feeling of well-being. We also have self-monitoring of blood glucose, or SMBG. Blood glucose monitoring is a cornerstone of diabetes management. It is a method of capillary blood glucose testing in which the patient pricks his or her finger and applies a drop of blood to a test strip that is ready for a meter. It is recommended that SMBG occurs when circumstances call for it, for example, before meals and snacks, for patients prescribed with frequent injections or an insulin pump. Using SMBG and learning how to respond to the results enable people with diabetes to individualize their treatment regimen to obtain the optimal blood glucose control. It allows for detection and prevention of hypoglycemia and hyperglycemia and plays a crucial role in normalizing blood glucose levels, which in turn may reduce the risk of long-term diabetic complications. We also have your continuous glucose monitoring system, or CGMS. It is used to continuously monitor blood glucose levels. A sensor is attached to an infusion set, which is similar to an insulin pump infusion set, and it is inserted subcutaneously in the abdomen and connected to the device worn on the patient clothing and placed in a pocket. After 72 hours, the data from the device are downloaded and blood glucose readings are analyzed. Although the CGMS cannot be used for making decisions about specific insulin doses, it can be used to determine whether treatment is adequate over a 24-hour period. This device is most useful in patients with type 1 diabetes. We also have your glycated hemoglobin, also referred to as glycosylated hemoglobin or hemoglobin A1C or A1C. It indicates your average blood glucose level for the past 2 to 3 months, and it measures the percentage of blood glucose attached to hemoglobin. We also have interpretation for this. An A1C level of 6.5% or higher on 2 separate tests indicate that you have diabetes. An A1C between 5.7 and 6.4% indicates pre-diabetes, and below 5.7 is considered normal. Now let's discuss ketones. These are the byproduct of fat breakdown, and it accumulates in the blood and urine, and it signals that there is a deficiency of insulin, and control of type 1 diabetes is deteriorating or not effective. Now let's proceed to insulin therapy. Insulins may be grouped into several categories based on the onset, peak, and duration of action. First, we have your rapid-acting insulins. It produces more effect that is of shorter duration than regular insulin. Because of their rapid onset, the patient should be instructed to eat no more than 5 to 15 minutes after injection. We also have your short-acting insulins. These are called regular insulin. Regular insulin is a clear solution and is usually administered 20 to 30 minutes before a meal, either alone or in combination with a longer-acting insulin. Regular insulin is the only insulin approved for intravenous use. We also have your intermediate-acting insulin. These are called NPH insulin or neutral protamine hagedorn or lente insulin. Intermediate-acting insulins, which are similar in their time course of action, appear white and cloudy. If NPH or lente insulin is taken alone, it is not crucial that it should be taken 30 minutes before the meal. However, patients should eat some food around the time of the onset and peak of these insulins. Lastly, we have your very long-acting insulins, also known as peakless basal. The insulin is absorbed very slowly over 24 hours and can be given once a day. Because the insulin is a suspension with a pH of 4, it cannot be mixed with other insulins because this would cause precipitation. We have here a table with the time course, the agents, the onset, the peak, and duration of the categories of insulin. We also have the insulin's time course and action. So we have here a line graph illustrating the insulin effect and the time or hours of its duration. We also have here the different categories of your insulin. We have your rapid-acting, short-acting, intermediate-acting, and long-acting insulins. Now let's proceed to oral antidiabetic agents. First, we have your thiazolidinoids, a class of oral antidiabetic medications that reduces insulin resistance in target tissues, enhancing insulin action without directly stimulating insulin secretions. We also have your sulfonylureas. It is a class of oral antidiabetic medication for treating type 2 diabetes, and it stimulates insulin secretion and insulin action. Now let's proceed to the nursing management. Nursing management of patients with diabetes can involve treatment of a wide variety of physiologic disorders, depending on the patient's health status and whether the patient is newly diagnosed or seeking care for an unrelated health problem. Glucose control in patients diagnosed with diabetes as well as those who have not been diagnosed is an important consideration in the hospital setting. First, we have managing glucose control in the hospital setting. Hyperglycemia can prolong lengths of stay and increase infection rates and mortality. Thus, nurses need to address glucose management in all hospital patients. We also have providing patient education by way of developing a diabetes education plan, assessing readiness to learn, educating experienced patients, and determining education methods. We also have promoting home and community-based care by way of educating patients about self-care and continuing care. Now let's proceed to acute complications of diabetes. There are three major acute complications of diabetes related to short-term imbalances in blood glucose levels, namely hypoglycemia, diabetic ketoacidosis or DKA, and hyperglycemic hyperosmolar syndrome or HHS. Now let's discuss hypoglycemia. It means low sugar in the blood, and it occurs when the blood glucose falls to less than 70 milligrams per deciliter. We also have a condition called severe hypoglycemia. The patient's blood glucose level is less than 40 milligrams per dl. We also have three causes of hypoglycemia. First is if there is too much insulin or oral hypoglycemic agents taken by the patient. We also have too little food ingested by our patient, and of course, excessive physical activity. And these three conditions cause hypoglycemia to our patient. For the clinical manifestations of hypoglycemia, it is grouped into two categories. We have adrenergic symptoms and central nervous systems or CNS symptoms. First, we have your mild hypoglycemia. In mild hypoglycemia, as the blood glucose level falls, the sympathetic nervous system is stimulated, resulting in a surge of epinephrine and norepinephrine. This causes symptoms such as sweating, tremor, tachycardia, palpitation, and nervousness and hunger. We also have moderate hypoglycemia. In moderate hypoglycemia, the drop in blood glucose level deprives the brain cells of needed fuel for functioning. Signs of impaired function of the CNS may include inability to concentrate, headache, lightheadedness, confusion, memory lapses, numbness of lips and tongue, slurred speech, impaired coordination, emotional changes, irrational or combative behavior, double vision, and drowsiness. Any combination of these symptoms, in addition to adrenergic symptoms, may occur with moderate hypoglycemia. In severe hypoglycemia, the CNS function is so impaired that the patient needs the assistance of another person for the treatment of hypoglycemia. Symptoms may include disoriented behavior, seizure, difficulty arousing from sleep, or loss of consciousness. For the management of hypoglycemia, we have first treating with carbohydrates. Immediate treatment must be given when hypoglycemia occurs. The usual recommendation is for 15 grams of fast-acting concentrated source of carbohydrate. It is not necessary to add sugar to juice even if it is labeled as unsweetened juice, because the fruit sugar in juice contains enough carbohydrate to raise the blood glucose level. Adding table sugar to juice may cause a sharp increase in the blood glucose level, and patients may experience hyperglycemia for hours after treatment. We also have initiating emergency measures. In emergency situations, for adults who are unconscious and cannot swallow, an injection of glucagon 1 mg can be administered either subcutaneously or intramuscularly. Glucagon is a hormone produced by the alpha cells of the pancreas that stimulates the liver to break down glycogen, the stored glucose. Injectable glucagon is packaged as a powder in 1 mg vials and must be mixed with a diluent immediately before being injected. After injection of glucagon, the patient may take as long as 20 minutes to regain consciousness. We also have providing patient education. Patients, family members, and co-workers must be instructed to recognize the symptoms of hypoglycemia. Family members in particular must be made aware that any subtle change in behavior may be an indication of hypoglycemia. They should be taught to encourage and even insist the person with diabetes to assess blood glucose levels if hypoglycemia is suspected. Next, we have your diabetic ketoacidosis. This is one of the acute complications of diabetes. It is caused by an absence of markedly inadequate amounts of insulin in type 1 diabetes. So basically, this is a complication of your type 1 diabetes. We have three main clinical features of this complication. First is hyperglycemia. Next, dehydration and electrolyte losses, and lastly, we have acidosis. For the clinical manifestations of your DKA or diabetic ketoacidosis, we have polyuria, polydipsia, marked fatigue, acetone breath or fruity odor. This is because of the presence of ketone bodies. Koshmal's respiration. This is a mechanism of the body to get rid of excess ketones. Blurred vision, weakness, orthostatic hypotension, and headache. For the assessment and diagnostic findings, we have patients with DKA has a blood sugar or blood glucose level of 300 to 800 milligrams per deciliter. And they also have low serum bicarbonate ranging from 0 to 15 mEq per liter and low pH values because of the presence of ketone bodies. Remember that your ketone bodies are acidic in nature. We also have low partial pressure of carbon dioxide because of hyperventilation and Koshmal's breathing or respiration. And of course, there is an accumulation of ketone bodies. For the management of patients with DKA, we have rehydration. In dehydrated patients, rehydration is important for maintaining tissue perfusion. In addition, fluid replacement enhances the excretion of excessive glucose by the kidneys. The patient may need as much as 6 to 10 liters of IV fluid to replace the fluid losses caused by polyuria, hyperventilation, diarrhea, and vomiting. We also have your restoring electrolytes. The main electrolyte of concern during treatment of DKA is potassium. The initial plasma concentration of potassium may be low, normal, or high, but more often than not tends to be high from disruption of the cellular sodium-potassium pump in the face of acidosis. Therefore, the serum potassium level must be monitored frequently. We also have reversing acidosis. Ketone bodies, which are acidic in nature, accumulates as a result of fat breakdown. The acidosis that occurs in DKA is reversed with insulin, which inhibits fat breakdown, thereby ending ketone production and acid buildup. Next complication is hyperglycemic hyperosmolar syndrome, or HHS. It is a metabolic disorder of type 2 diabetes resulting from a relative insulin deficiency initiated by an illness that raises the demand for insulin. And basically, this is the complication of your type 2 diabetes. It alters sensorium or sense of awareness of our patient. Now let's have the clinical manifestations. We have hypotension, profound dehydration, tachycardia, and variable neurologic signs. For the assessment and diagnostic findings, we have a blood glucose level that is usually 600 to 1,200 milligrams per deciliter, and the electrolyte and BUN levels suggest dehydration. And of course, the mental status of our patient changes, and postural hypotension. Now let's proceed to the management of your HHS. The overall approach to the treatment of HHS is similar to that of DKA: fluid replacement, correction of electrolyte imbalances, and insulin administration. Because patients with HHS are typically older, close monitoring of volume and electrolyte status is important for prevention of fluid overload, heart failure, and cardiac dysrhythmias. We also have possible nursing diagnosis for both diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. We have risk for deficient fluid volume related to polyuria and dehydration. We also have risk for electrolyte imbalance related to fluid loss or shifts, and deficient knowledge about diabetes self-care skills and information. And lastly, we have anxiety related to loss of control, fear of inability to manage diabetes, misinformation related to diabetes, and fear of diabetes complication. We also have potential complications, namely fluid overload, pulmonary edema, and heart failure, hypokalemia, hyperglycemia and ketoacidosis, hypoglycemia, and cerebral edema. So these potential complications are a result of the treatment as well as the disease process of diabetes. For the goals of care, the major goals for the treatment may include maintenance of fluid and electrolyte balance, increased knowledge about diabetes survival skills and self-care, decreased anxiety, and absence of complications. Now let's proceed to the nursing interventions. First is maintaining fluid and electrolyte balance. We also have increasing knowledge about diabetes management, decreasing anxiety, monitoring and managing potential complications, and educating patients about self-care. Now let's proceed to long-term complications. The number of deaths attributable to ketoacidosis and infection in patients with diabetes has steadily declined, but diabetes-related complications have increased. Long-term complications are becoming more common as more people live longer with diabetes. These complications can affect almost every organ system of the body and are a major cause of disability. The general categories of long-term diabetic complications are: first, we have your macrovascular complications. It results from changes in the medium to large vessels. We also have your microvascular disease or complications. It is characterized by capillary basement membrane thickening. And also we have your diabetic neuropathy. It refers to a group of diseases that affect all type of nerves, including peripheral sensory motor, autonomic, and spinal nerves. For the macrovascular complications, we have coronary artery disease, cerebrovascular disease or stroke, and peripheral vascular disease. For your microvascular complications, we have diabetic retinopathy. This is a complication of diabetes in which the small blood vessels that nourish the retina in the eye are damaged. We also have your nephropathy. It is a long-term complication of diabetes in which kidney cells are damaged. It is characterized by microalbuminuria in early stages and progressing to end-stage kidney disease. So this is your diabetic nephropathy, wherein the protein leaks from blood vessels to Bowman's capsule in the kidney. Now let's proceed to diabetic neuropathies. We have peripheral neuropathy, also known as sensory motor polyneuropathy. It affects the distal portion of the nerves, especially the nerves of the lower extremities. and it affects both sides of the body symmetrically and spread in a proximal direction. We also have autonomic neuropathy. It results in a broad change of these functions affecting almost every organ system of the body. We also have your pseudomotor neuropathy. It is a neuropathic condition. It refers to a decrease or absence of sweating, anhidrosis of the extremities with a compensatory increase in upper body sweating. Dryness of feet increases risk for foot ulcers. Now let's proceed to foot and leg problems. Complications that increase risk of foot problems and infections include neuropathy. Sensory neuropathy leads to a loss of pain and pressure sensation, and autonomic neuropathy leads to increased dryness and fissuring of the skin, secondary to decreased sweating. Motor neuropathy results in muscular atrophy, which may lead to changes in the shape of the foot. We also have peripheral vascular disease. Poor circulation of the lower extremities contributes to poor wound healing and the development of gangrene. Lastly, we have your immunocompromise. Hyperglycemia impairs the ability of specialized leukocytes to destroy bacteria. Therefore, in poor controlled diabetes, there is a lowered resistance to certain infections. Now let's proceed to special issues in diabetes care. First, we have patients with diabetes who are undergoing surgery. During periods of physiologic stress, such as surgery, blood glucose levels tend to increase because levels of stress hormones such as epinephrine, norepinephrine, glucagon, cortisol, and growth hormone increase. If hyperglycemia is not controlled during surgery, the resulting osmotic diuresis may lead to excessive loss of fluids and electrolytes. Patients with type 1 diabetes also risk developing ketoacidosis during periods of stress. We also have management of hospitalized patients with diabetes. Often, diabetes is not the primary medical diagnosis, yet problems with control of diabetes frequently result from changes in the patient's normal routine or from surgery or illness. Patients who are hospitalized and have a diagnosis of diabetes should have this clearly indicated on their medical record, and glucose monitoring needs to be prescribed. Under your management of hospitalized patient with diabetes, we have self-care issues, hyperglycemia and hypoglycemia during hospitalization, common alteration in diet such as NPO, clear liquid diet, enteral tube feedings, and parenteral feedings, because these can affect their blood glucose level. We also have hygiene. Nurses caring for hospitalized patients with diabetes must focus attention on oral hygiene and skincare. Because these patients are at increased risk of periodontal disease, the nurse assists with daily dental care. The patient may also require assistance in keeping the skin clean and dry, especially in areas of contact between two skin surfaces, where fungal infections tend to occur. We also have stress. Physiologic stress such as infections and surgery contributes to hyperglycemia and may precipitate DKA or HHS. Emotional stress related to hospitalization for any reason can also have a negative impact on diabetic control. An increase in stress hormones leads to an increase in glucose levels, especially if intake of food and insulin remains unchanged. Now let's proceed to the nursing management. First is monitoring and managing complications. Assessing for hypoglycemia and hyperglycemia involves frequent blood glucose monitoring, usually prescribed before meals and at bedtime, and monitoring for signs and symptoms of hypoglycemia or prolonged hyperglycemia, including DKA and HHS. We also have promoting home and community-based care by way of educating patients about self-care and continuing care at home. I believe this is the end of our lecture on the management of patients with diabetes. Thank you so much for listening.